So good morning. That was a great talk by Dr. Mangrum. I'm not certain whether she's a supporter of the robot or not, though. I'm a little ambivalent whether she is. Good morning. I'm going to talk about the top 10 papers in general surgery. If I'd have known who the 10 of y'all were, I would have listed a paper from each of y'all in this talk. So thanks to some friends who helped me. I don't consider myself the best top 10 paper. I don't actually really agree with the concept, so it's a challenge. But thanks to some friends who helped pull these together. So I just sort of try to think about, critical topics for 2020, 2019. I think you can break them down into, whenever I think about bread and butter general surgery, there's no question that the pandemic has been a challenge for everyone across the world. We're clearly all in this together, but it's probably burnout and fatigue are probably at all-time highs in the modern world. So I'm going to just briefly talk about 3 presidential addresses that I think are terrific. I'm going to talk a little bit about appendicitis, cholecystitis, metabolic bariatric surgery, and trauma. This is a great presidential address by Kelly McMasters. He has a couple, actually. This is his Southern Surgical, and his Western Surgical is also terrific. He titled this Random Truths and Universal Nonsense. He's got a whole bunch of brief, very readable, easy to read, and I really commend this to all of us, and his Western Surgical address as well. He talks about dogs here. Dogs may not have the capacity to reason, but they have an amazing capacity to love boundlessly, unabashedly, and unconditionally. The dogs think that man's capacity to reason is what often makes humans so unreasonable. So remember, you can learn a lot from man's best friend. For those of you who know Dr. McMaster, his son, he lost his son to a battle with cancer, Owen. And I'm just going to read his quote here. Owen taught me a great deal throughout his battle with cancer. Although it's taken some time, I've learned to be thankful for this time with Owen during his illness. It's the best thing I've ever done. You see, I have many faults. I'm not always kind and generous. I'm impatient and easily frustrated. I judge when I should accept. I'm more selfish than selfless. I sometimes give presidential addresses pretending to teach lessons that I've not even learned myself. I may not be the best teacher, scientist, surgeon, or person. But for a while, just a little while, I think I was a pretty good dad. And maybe that's enough. So for me, if you think about the people in your life, being a good friend, a good dad, a good partner, that's enough. That's enough. Towards the end of his address, he's musing. He says, "So remember, with sadness, there is joy. With tragedy, there are blessings." Sorry. You just need to remember to look for them. Perhaps without evil, there is no good. Perhaps without despair, there is no hope. And perhaps without grief, there is no love. I really commend this address. It's be great to read on the plane on the way back. Dan Margulis, our past president, had a great view. Dr. Margulis, if you remember, grew up in Hawaii. And he has 15 things that he learned with respect to surfing. I'm not going to go over all 15 of them, although it would be a good use of our time to do that. But I'm going to talk about 12 and 13. He says failure is part of the learning process. And he has a picture of a photo of a surfer crashing badly. Do enough cases and you'll have a case at M&M conference. Learn from your failure. Don't be destroyed by it. Have fun. Don't forget about humor. Clearly capturing the power of the wave the flying through the air with no engine, but the power of the water itself is invigorating and tons of fun. So is the art we practice in surgery. All the serious consequences can be daunting, but don't forget to have fun. Kids know how to have fun. Why do we adults sometimes lose that? I've made the case that operating is art and creating art is enjoyable, so enjoy it. My kids know I can find something funny in even the most mundane of things, like a street sign. The next presidential address is Courtney Scaife's, putting patients first. For those of you who were there, you know that Dr. Scaife made a real push plea with pragmatic steps to put patients first. And, I think she was well ahead of the pandemic here when she talked about postmodernism. She's talking about, she might as well have been talking about the pandemic in people's response. But she said the postmodernistic person is more likely to believe in a blog post than a medical journal publication. These patients believe in cosmetic lotions and essential oils, non-regulated dietary supplements, anti-vaccines, but are not willing to believe in antihypertensives you prescribe. The modern patient learned to believe in social lore about untested supplements more than they believe in you, the practicing Western medicine provider. And she gave a path to how we can regain that trust, and really putting the patients first on multiple levels. Here she's talking about a talk she was at with Dr. Bass, Barbara Bass, and she said as she was listening to her talk, Dr. Bass, the title of her talk is "We Must Be Well to Do Well." And as she was listening to her talk, she realized that the opposite is also true. We must do well to be well. We must do well to be well. If we take good care of our patients and if we make a bond with the patients, again, where we can feel like a healer, we won't burn out. And there's evidence to support this. So now I'll move on to appendicitis. I really do think whatever you find, before I go to appendicitis, I really do think whatever you personally find meaningful and uplifting, I would encourage you to go to that routinely. But there are voices of clarity and peace and calm speaking today all around the world. We just have to be looking and listening. So this is more evidence. This is a great randomized clinical trial looking at antibiotic-only treatment of acute uncomplicated appendicitis out of Ireland. The results of the COMMA trial. It's in the Annals of Surgery. This is just a histogram looking at time to recurrence with antibiotic-only treatment. You can see that there's lots of recurrences, and those occurred from anywhere from 1 day after antibiotic therapy was stopped to 300 to almost a year. And really, if you get to the meat of the paper, they follow the patients at 1 week, 1 month, and 3 months. And if you move over here to the 12-month period, you can see that the antibiotics only period had the proportion who said they were in full health was 44% compared to 88% of those who had had an appendectomy first. And if you look at the patients who did particularly poorly, those are patients who were treated with antibiotics and then failed that treatment and then required an appendectomy at a year, excuse me, at 12 months. None of them said that they were in full health. So they conclude that patients with acute uncomplicated appendicitis treated with antibiotics only have high recurrence rate and inferior quality of life. So surgery should remain the mainstay of treatment in this most commonly encountered acute surgical condition. Dr. Kathari talked about this yesterday in this great panel. He talked about this multi-center observational study done from the Southwest Surgical Congress. It's very simple, but I think it shows the power of working together. It also shows that, I'll say it's the conclusion, they realized that when they looked at patients who were being assessed, those who had increased bilirubin, increased liver function tests, we were all over the map with respect to what we were doing with respect to evaluating those patients, from pre-op ERCP, pre-op MRCP, intraoperative IOC, all sorts of, almost a dozen different approaches to them. And really that group came up with a standardized approach, operate early, use a standardized protocol. We just took that and I didn't, but our team took that and went back and basically made a standardized guideline for our team. We have a whole bunch of people doing cholecystectomy and standardize that in many ways based on that paper. So a very simple paper, but really powerful. I think it's made a difference in our practice. This is a paper this May in the Lancet, Association of Metabolic Bariatric Surgery with Long-Term Survival in Adults with and Without Diabetes, a one-stage meta-analysis matched cohort of 174,772 participants in the Lancet. And you can see this is really the meat of the trial. This is cumulative mortality on the y-axis. And this is non-surgical controls versus surgical controls. You can see over time, 1 year, 3 year, 5 year, 10 year, 30 year, the difference in mortality. I know many of you know this already, but that difference was most marked in the patients who have diabetes. These are patients who had diabetes and those who didn't have type 2 diabetes. So basically, they conclude that metabolic bariatric surgery is associated with a substantially lower all-cause mortality rates and longer life expectancy among adults with severe obesity. And with reasonably low numbers needed to treat to prevent one additional death within 10 years, they conclude there's substantial greater survival benefits in patients with pre-existing diabetes. And they recommend that clinicians and policymakers should not hesitate to consider metabolic bariatric surgery in the management of patients with obesity and type 2 diabetes. For COVID, it's not any different than trauma and emergency healthcare. It's not any different than elective healthcare or surgical oncology or any other field in medicine, but cooperation and communication save lives. Cooperation and communication save lives. Think about the tremendous amount of lack of cooperation and clouded communication, sometimes even intentional miscommunication. It leads to death in emergency healthcare. That's just how it is. So this is a paper from Dr. Bulger and Dr. Mitchell out of Washington State, Harborview, where they basically put together a regional medical operations center. This has been a project of the Committee on Trauma for the past 5 or 6 years, but Dr. Bulger's really pushed this forward. There's handfuls of places across the country that have regional medical operations centers. And so they established such a center. I'm not going to go through the whole paper, but they called it the Western Washington Regional COVID Coordination Center, whose job was to get situational awareness with respect to what across the entire region, what was going on at local areas and even down to local institutions, what beds were available, and to track those. So they had surveillance of hospitals and health systems, tracking bed availability, resources, ventilators, staffing. And then they worked on surveillance of congregate care settings, particularly skilled nursing facilities, shelters, jails, prisons, long-term care facilities. So they tracked resources, patients in these settings routinely, daily. We do this too in South Texas. We call it our Regional Medical Operations Center. And then they work to coordinate those resources based on that surveillance and worked on load balancing. If you remember, Seattle was the first major outbreak with COVID in the United States, and it really started at a single healthcare facility who was at risk for becoming overwhelmed. And this system allows for load balancing, situational awareness, and the ability to match patient need to resources. Next paper is timing of surgery following SARS-CoV-2 infection, an international prospective cohort study from the NIHR Global Health Research Unit in Birmingham, UK. And they basically looked, this is a global study of 140 countries, I think, where they looked at mortality by timing of surgery, patients who required surgery, 0 to 2 weeks, 3 to 4 weeks, 5 to 6 weeks, greater than 7 weeks. And you can see that by greater than 7 weeks, it was close to baseline. If you look, the greatest difference for this, and there's some things that make it a challenge to operationalize their goals. One of them is that emergency surgery was actually had one of the greatest differences. You can see here's compared to no patients without a SARS-CoV-2 infection in greater than 7 weeks. You can see that emergency surgery compared to elective surgery. So there's challenges with respect to obviously delaying those greater than 7 weeks. Major surgery and high ASA grades had the greatest increase in mortality with early operation. But they concluded that in this study of 140,000 patients, that's 116 countries, not 140, that waiting to at least 7 weeks, if that's possible, could patients' mortality risk for anesthesia goes back to baseline. Moving on to trauma, this is there's quite a few number of surgeons who've been at this meeting who actually have done work with beta blockers in traumatic brain injury. This is a systematic, up-to-date review and meta-analysis from a group of investigators out of China. You can see that generally there is benefit on the force plot for beta blockade compared to no beta blockade. And they concluded this is that administration of beta blockers after traumatic brain injury was safe and associated with improved survival, better functional outcome. And so they basically recommend that becoming a routine, although basically they do comment, which is true, that more high quality trials are needed to investigate timing and type of beta blockers. Moving on to resuscitation. This is a paper from Bilal Joseph's group out of Arizona, a nationwide analysis of whole blood for hemostatic resuscitation, civilian trauma. I think many are aware, but maybe some in the audience aren't aware that learning from experience in Afghanistan and Iraq, there's been a group of people who've been patiently and consistently advancing the concept of cold stored O positive whole blood. Sorry, I'm going the wrong way. So there's quite a few centers now who are doing whole blood, both in hospital and outside of the hospital. And so they looked at whole blood and whole blood combined with component therapy. And from this TQIP analysis, it did look like that there is some survival advantage, obviously 24-hour mortality. Some people look at that to see the effect on bleeding, but obviously 30 or 90-day mortality is a much better benchmark. But in-hospital complications from blunt trauma appeared better with whole blood, and in-hospital mortality also appeared to be significantly different in this study. They conclude that whole blood is an adjunct to component therapy in resuscitation appears to be associated with improved survival compared to component therapy alone. And it was accompanied by a decrease in hospital length of stay and overall major complications. They conclude that prospective randomized clinical trials are warranted. I really believe this is true. That this particular paper is definitely at a great risk for selection bias, that centers who are early adopters for this may be doing things differently. But I will say that cold stored whole blood is simpler, at least a less blood exposure, and it definitely facilitates resuscitation compared to component therapy. We have a whole blood consortium. We have a group of donors who routinely donate for this. We have a regional blood program that's both in pre-hospital and hospital. It's been a great success. But more to come with this. There's definitely needs to be more data with respect to randomized trials. Couple of papers looking at hypocalcemia from, I'm sorry, Chris, I'm having trouble with the mouse. It's not your mouse, it's me. Looking at post hoc analysis of two trials, Pamper and the Combat trial, the hypocalcemia group was associated with decreased survival probability when compared to those who were normal calcemic, and the worst group was the control group with hypocalcemia. So we often attribute hypocalcemia due to blood administration, but it's likely it's much more complicated. It happens before blood administration occurs. So there did appear to be a slight decreased survival with respect to hypocalcemia. So Moore and colleagues conclude that because this is a risk factor for early death along with lethal triad, and that 1 gram of calcium be given for every 1 to 2 units of blood products that have plasma included. So aggressive replacement of hypocalcemia. Somehow I missed a paper. I did. Okay, so I lumped 2 papers together. This is my mouse challenged state. With this paper from Ricky Ditzel and Jeffrey Siegler out of Raleigh, North Carolina. They a long list of group of investigators, but they basically talked about the lethal diamond versus the lethal triad, adding that hypocalcemia creates problems in every one of these areas, and hypothermia, coagulopathy, and acidosis can exacerbate hypocalcemia. So lots of gaining evidence for early and aggressive treatment of hypocalcemia. I'm going to wrap up with this paper by Bolger and colleagues, proceedings from the Medical Summit on Firearm Injury Prevention, a public health approach to reduce death and disability in the U.S. This happened really shortly before the pandemic. So obviously many things have been a distraction during the pandemic, but as we heard in this meeting, and as numerous other investigators from across the country are observing, that during the pandemic time period that firearm injury, both certainly interpersonal violence and possibly self-harm have significantly increased during that time period. So this was pre-pandemic, and 47 medical organizations basically came together. This conference was framed using what the American College of Surgeons Committee on Trauma calls the common American narrative, that we Americans tell ourselves 2 different simple stories about firearms. One I'll call the firearm freedom narrative, which goes something like this: firearms are generally beneficial, they're critically important for personal protection, it's a constitution protected right, and the person who really holds that closest to their heart feels that the firearm is an emblem of freedom. You can pretty much substitute freedom and gun, and they're synonymous. So gun control to that person translates to freedom control. About 40% of people, 40% of surgeons hold that story. About 40% of surgeons hold the what we call the firearm and violence narrative, that goes something like this: firearms are generally harmful. They're generally unnecessary in modern civil life. They actually decrease personal liberty because of the risk of harm in our communities and in our homes. And for the person who holds that story closest to their heart, the gun is an emblem of violence. So gun control in that person's mind synonymously translates into violence control. And these 2 sides often basically talk at each other or even yell at each other. But through a consensus building process over several years, including multiple surveys, we've realized that it is possible to have a common story, a common narrative, and it goes something like this. And I would encourage everyone in this room to hold this narrative because it doesn't take any compromise. It takes no compromise if you're a fireman violence person or fireman freedom narrative. It goes something like this. It's intentionally inclusive of both the narratives. That firearm ownership is a constitutionally protected liberty, but we have a major, but violence is a major cause of preventable death and suffering. I know many of you know that 100 to 110 people die every day as a result of firearm deaths. 60% of those are self-harm. But what many people also look at is there's about another 70 or 70 to 80 who die from other causes of intentional violence. So each day in the United States, 184 people die every single day from intentional violence. By that, I mean self-harm or harm to another person. So we have a huge violence problem. As I said in discussion of one of the papers, I believe it is the most neglected and under-addressed public health problem in the United States by a long margin. But so we can address that by working together to understand and address the underlying causes of violence while making firearm ownership as safe as possible. So that meeting was framed in that, and these 47 organizations, really every major professional organization in the United States came together, and all of those organizations supported all of these statements, that firearm injury in the US is a public health crisis, that a public health and medical approach is needed, research is needed to better understand the root causes of violence, federal and philanthropic research funding should match the disease burden for those trauma surgeons and non-trauma surgeons in the room. That's about $1.5 billion. It's currently funded like in the, well, we had success in the ACS. It was a key advocate for it. We had success in about 25 million, so 25 to $50 million. It's an order of magnitude off funding. Engage firearm owners and populations at risk are critical to developing good strategies, and healthcare providers should be encouraged to counsel patients and families regarding safe storage and firearm safety. We should be screening for the risk of depression, suicide, intimate partner violence, interpersonal violence across all of our healthcare settings, and health systems must engage the community in which the community they serve by addressing social determinants of health, including investing in those communities. And those professional organizations committed to working together to ensure the health and well-being of fellow Americans using a medical and health approach. So wrapping up our top 10, great wisdom and wellness from Drs. Kelly McMaster, Dan Margulis, and Courtney Scaife. There's more high quality evidence that early appendectomy leads to better outcomes and quality of life and uncomplicated, straightforward appendicitis. Implementing the Southwest Surgical's multi-institutional studies recommendation does really standardize the approach to cholecystectomy and IOC. And there's more high quality evidence that metabolic bariatric surgery improves mortality, particularly in those with type 2 diabetes. On the trauma front, in the pandemic response, a regional medical operations center is critical to an effective response to any wide-scale disaster. In those areas that have it, have been much more nimble and able to respond to the pandemic. If you don't have an RMOC, you need to have one. With respect to shock resuscitation, emerging evidence that cold stored whole blood is simpler, leads to less product exposure, and may be associated with improved outcomes. And hypocalcemia looks like it may be associated with mortality independent of some of those factors, leading to, trying to people get a catchy title, the lethal diamond. More evidence that beta blockers for traumatic brain injury improves mortality and outcomes. And around firearm injury and intentional violence, consensus is possible. It's not just possible, it's been proven that it's possible. It's been proven and with a very opinionated group of surgeons in the Committee on Trauma. It's very clear that people who love guns and hate guns can work hand in hand together to reduce unnecessary death and suffering related to intentional violence and firearm death. So that means that I have to commit to addressing root causes of violence while working to make firearm ownership as safe as possible. Thank you all very much. And I think maybe I've 30 minutes ahead of schedule, which is a plus at this time.